This is the Shelbourne Knee Center podcast. This is Dr. Benner, and I'm here with Scott Bauman, my co-host, and we're going to do another episode tonight of Patient's Place, where we talk about medial meniscus tears. If you want to check out our previous Patient's Place episodes, these are episodes that are more geared towards patients who want some education in more layman's terms to learn about their conditions. We have one about knee arthritis. We have another one about ACL graft choices. This will be, I believe, the fourth installment of that series. Tonight, we're going to talk about medial meniscus tears. If you'd like to catch us on social media, you can find us on Instagram and Twitter at the SKC Podcast. You can go to our Facebook and YouTube pages for the Shelbourne Knee Center Podcast. And if you'd like to email us, you can email us at the skcpodcast@gmail.com.
Well, let's jump right in. You mentioned we were going to talk about medial meniscus tears tonight, and I think this is going to be a great topic for Patient's Place, and similar to the episode we did on osteoarthritis, mainly because of just the sheer numbers of patients that we see coming in with this. And I know this is one of the more popular diagnoses that we can see, at least from a more of a degenerative standpoint, but we may get into both the acute and the degenerative types. But first and foremost, let's first talk about the difference between those two types of tears, both being a meniscus tear. I mentioned more of the acute type of an acute injury, as well as a degenerative tear. So first and foremost, can you get us started by describing those two different types of tears?
Yeah, I mean, they're definitely far different populations. The majority of acute tears in younger people happen with ACL tears. So it's actually pretty uncommon for people to get a meniscus tear on the medial side of the knee, except in a couple specific situations, unless they tear their ACL. So lots of young people who tear their ACL get acute tears where the meniscus goes from a normal meniscus to a torn meniscus all at once. But the majority of tears that we see are more degenerative in nature. Now, people, when they hear that, they may think, well, I don't have a degenerative knee. My doctor says I don't have arthritis, but I have a degenerative meniscus tear. That doesn't make any sense. And the reason is it's not that it's supposed to delineate, did the meniscus go from a normal meniscus to being torn all at once, or did it slowly tear and slowly become degenerative over time? And very similar to what we talked about in our osteoarthritis episode that we had in Patient's Place from previously that everyone should check out. The meniscus can change in quality over time. Actually, on a microscopic level, the meniscus becomes more susceptible to kind of degenerative and chronic damage from repeated kind of micro level injury to the meniscus, just from squatting and twisting, just from doing, activities with their knees in a bent position, and the meniscus can kind of wear out and become degenerative over time. So it's an important distinction when we're thinking about meniscus tears to realize, one, that the majority of these are degenerative in nature and happen in older people unless they are at the time of an ACL tear, which happens more in young people. So a lot of people come to our office and say, well, I have pain, young people who have pain in their knee, and they say, I think I could have a meniscus tear, but they have no injury. They have an intact ACL. They don't play a high-risk sport. And in that case, it's pretty uncommon, almost never happens in that population.
Well, let's dive into the details more on that, the first category you talked about, the degenerative type, since that seems to be the majority of patients that come in with the medial meniscus tear. What are some common signs, symptoms, those types of things for that middle-aged population that has a degenerative tear?
Well, the majority of these are, as we said, are degenerative in nature, meaning they're more chronic tears, that they happen a little bit at a time over a longer period of time. You don't go from having no symptoms to having a torn meniscus at the drop of a hat from a specific injury. So most of these patients will be over the age of 40, even more over the age of 50, and they'll come in saying, I didn't do anything. I just was all of a sudden one day started noticing some pain on the inside of my knee without any injury. I didn't have an increase in activity. I didn't hurt myself. I didn't fall. I didn't do anything. And all of a sudden I just had pain on the inside of my knee. And that's an important distinction for meniscus tears as opposed to other kinds of more traumatic things where people say, I was totally fine until I jumped and landed and fell in this way onto my knee, which is less likely to be a meniscus tear. The patients with degenerative tears, in addition to saying that they didn't have any specific episode that kind of kicked things off, will have pain on the medial joint line. And the medial joint line means the inside part of the knee, and it's mostly all the way around the side of the knee. A lot of people will say, well, if it hurts on the inside, it should hurt up here in the front, and they'll kind of point to the front of the inside of their knee, where in reality, most of the meniscus tears tears that most of the degenerative tears that we find hurt at the posterior medial joint line or towards the back of the knee, all the way around the inside of the knee. And we have to kind of point that out to them. If you hurt up here in the front, like just in the area just to the inside of the patella tendon or to the inside of the kneecap, most things that hurt in that area would not be meniscus tears. It would be further around the side of the knee for us to think about the diagnosis of a degenerative medial meniscus tear.
Now, going beyond the location of pain, is there anything that seems to trigger these patients on a consistent basis where they say, every time I do XYZ, it seems to hurt more than others? Is there something about these patients that seems to be a consistent complaint?
Well, you just asked one of my favorite questions in exactly the way I ask it. It's like you've heard me ask this to patients before or something. They do, and I ask that exact question. Is there a specific thing that bothers you that you do where you say, every time I do this specific activity causes my knee to hurt? And usually those will be things with their knee in a bent position. So they'll say, when I squat, or when I squat and twist, or when I do things with my knee loaded in a bent position. So getting something off of a low shelf, where they're kind of bending down on that knee, and then putting their knee in kind of a figure four position sometimes will hurt them, as well as some people will say, if my foot rotates out to the side, like if I'm turning around in a computer chair and I catch the inside of my toe on something, or if somebody rolls a ball to me and I kick it with the inside of my foot, which pushes my foot and my leg towards the outside, that really hurts on the inside part of the knee. Those are a few specific things that people will complain about. And then when we see them on physical exam, sometimes they'll be a little bit swollen. Most of the time they'll have good range of motion, but sometimes they can be a little bit stiff. And then we go into some more specific testing to try to decide for sure whether we think they have a meniscus tear.
Now, going back to the fact that most of these patients do not have any type of event that seems to cause this, is that 100% of the time, or do you ever get patients in the office where they say, you know what, I can actually remember I was moving a box and I squatted down, I twisted, or whatever? Is there any scenarios that you have heard in the clinic that patients seem to have an injury and then you actually diagnose them with a degenerative medial meniscus tear?
Yeah, those definitely happen as well. That's less common, but it does happen. A lot of times they said it'll be squatting and twisting. So somebody will say, I was helping somebody move and I squatted down to pick up a box. And then when I went to stand up, I felt a pop on the inside of my knee. That sometimes can point us to a meniscus tear on the inside of the knee. Again, the twisting of the foot to the outside, where somebody will say, well, I bent down to get something and then I turned and looked over my left shoulder. So my right foot pushed out to the outside, and that really caused a lot of pain over the inside of my knee.
Excellent. So once you have these patients in the office and you hear the story and they're kind of fitting the profile from their story as well as their demographic with their age and whatnot, and you kind of feel that this might be a medial meniscus issue, what's the next steps from an examination standpoint? What should that patient expect to occur at that time?
We always check their range of motion on the opposite knee first and examine the opposite knee first. That's really an important pillar of good physical exam for the knee, because it's a paired structure. Always go to the opposite side. So I check their extension, including hyperextension, and their flexion on their uninjured knee to make sure I kind of establish what normal is for them, make sure they're not having any swelling. And then I kind of push around on the joint lines with specific attention to the inside part of the knee, because some people, especially people who have maybe a little bit bigger legs, a little thicker soft tissue on the inside, sometimes it'll just be tender to push on the inside of their knee. And if they hurt on the uninjured knee, then if we go to the injured knee and it causes pain as well, then I'll know maybe they actually complained to that on their other side as well. So maybe it's not as convincing. But what I'm looking for on the normal knee is a normal knee exam. So if I find good range of motion, no swelling, no joint line tenderness, and then I do the more provocative tests like a McMurray's test, where I bend the knee all the way up, externally rotate the foot, and then push the foot out straight with a little pressure on the outside of the knee. That's designed specifically to trap a torn meniscus between the two bones and make it hurt on the inside part of the knee. So I do that on the opposite knee as well to establish, no, that doesn't hurt. It feels funny because you're twisting my knee, but it's not painful. And then when I go to the injured knee, usually I'm looking for whether there's a little bit of mild swelling, whether they have any restriction or range of motion, knowing that we know that it should match the uninjured knee that I just examined. And then I start pushing around on the joint lines. One of the most important important thing that for young practitioners starting out is you got to push on a lot of things that don't hurt before you go to the area that hurts. So the temptation is to just go to the inside part of the knee where they say it hurts, push in that area and say, yes, that hurt. But you always do that last. Go to the kneecap tendon, push on there, find that doesn't hurt. Push around the front of the knee on both sides, that doesn't hurt. Lateral joint line on the outside part of the knee doesn't hurt. And then kind of gradually move my thumb around and then push on the area of interest. And if they really say, ooh, that really hurts, yes, that's the spot. Well, after they've just told me no on everywhere else that I've pushed, that's really convincing that could be the issue. And then I like to use the McMurray's test, again, one where we hyperflex the knee, bend the knee all the way up, twist the foot and the lower leg to the outside, and then straighten the knee while putting a little pressure on the outside of the knee. That tries to trap the torn meniscus between the two bones and elicit pain or popping or both on the inside part of the knee. And if I'm seeing those things, joint line tenderness in the back of the joint line, some mild swelling, and positive McMurray's test, now I'm really starting to think I've gotten some physical exam evidence that fits with the story that the patient just told me, and that can lead us to the diagnosis.
Now, with other episodes on the Patient's Place series, we've talked about imaging, and you go to an orthopedic office, and you've told us before, you typically are going to get some type of imaging, and usually starting off with an x-ray. Now, knowing that this is a soft tissue, I'll call it injury, but soft tissue condition where the meniscus is torn, and you're not maybe able to see that on x-ray, is that something you're still starting with, or what do you feel like is the right call for you to make, and what should the patients expect and when it comes to imaging for this diagnosis?
Yeah, most orthopedic surgeons will get x-rays pretty much on everybody that walks in the door. But in when you're thinking about a meniscus tear in particular, meniscus tears, degenerative meniscus tears, if we're going to make that diagnosis, usually the x-rays should be normal. So some of those same kind of symptoms can happen with arthritic knees, where they have a little bit of mild swelling, the pain came up out of nowhere, maybe some limitation of range of motion, and some tenderness on the inside part of the knee, where you think possibly they could have a meniscus tear, and then you put up the x-rays and you see severe degenerative joint disease or severe arthritis on the inside. That will tell us that the meniscus tear is not the problem, the arthritis is the problem. So from an imaging perspective, I never go to an MRI scan, which is how you actually directly visualize a meniscus with imaging, until I've had negative x-rays. Almost never do we get an MRI scan looking for meniscus tears until we've had negative x-rays first.
Excellent. So you've done your evaluation, you've heard their story, and you've gotten all your imaging and figured out that this is a degenerative medial meniscus tear. What are you looking at from a treatment perspective for what's next?
A lot of it depends on how chronic it is. So if somebody comes in and says, I was fine until 2 weeks ago, and I twisted my knee getting up off the couch and felt a pop on the inside of my knee, and I've had pain on the inside of my knee for just a couple of weeks, and they have negative x-rays, they're not an athlete trying to get back to a sport on a specific schedule, things like that, we'll usually start with pretty standard, first line non-surgical treatment, icing the area, doing some stretching exercises with physical therapy to maintain range of motion, over-the-counter anti-inflammatory medicines, avoiding activities that seem to bother it, and just see if we can get it calmed down. Even if they do have a meniscus tear, if they've only been bothered by it for a couple of weeks, there's probably no reason to get an MRI scan, definitely no reason to think about surgery yet, and we don't harm anything by trying just some simple non-surgical treatment. So that's usually the first line. Versus if somebody comes and says, I've had this thing for 6 months. The popping's been getting worse. The swelling's been getting worse. It's been hurting me more and more. I've waited a long time with not doing my activities to try to get it better. And it just keeps getting worse. I can't handle this anymore. I want to have surgery if that's what it takes. Then we'll move a little bit faster through the pathway of getting imaging, but and potentially even to surgery relatively quickly. But if it's been bothering people for a short period of time, relatively short duration, then we'll usually try over-the-counter medicines, activity modification, some light stretching, some icing, real simple things like that to get things going on, see if we can get it to calm down that way.
Now, in terms of non-operative treatment, you mentioned anti-inflammatories, over-the-counter medications, and physical therapy. Is there any other treatment options that you are giving these patients?
Now, once we got past that first level of the anti-inflammatory medicine, sometimes we'll move on to steroid pills that people can take by mouth. If they say, I've already they come to the first visit and they say, I've been taking a leave for a week already and it's not really helping. I don't feel like it's making a difference. Then instead of just telling them to keep taking the same thing, which they've already been taking, sometimes we'll try some by mouth steroid pills that people can take. It's a little bit stronger, has a little more side effects, which we talk about with them, but we'll usually use a steroid dose pack for a couple of weeks. The most invasive but the most effective non-surgical treatment is probably an injection, a steroid injection inside the knee. And the steroid injection is more targeted just inside the knee. It pretty reliably decreases pain, relieves swelling, helps get inflammation under control. And a lot of times we'll do that before a surgery, especially if somebody comes in and says, I don't want surgery, but I'm having a significant amount of pain. I don't think that the anti-inflammatories are really helping me much. Is there something stronger that I can get that I'm willing to do something a little more invasive, but I still don't want surgery? Then we'll use injections.
Now, when you're going after this from a non-operative standpoint first, do you ever see people get better and then get worse again and have to do a reevaluation and decide on surgery after the fact?
Definitely. And a part of any non-surgical treatment protocol, whether it's degenerative meniscus tears or arthritic knee care, whatever, always has to have those kind of guidelines. This is what we're going to try now. If this works and things gradually get better, then that's all we need to do. However, if your symptoms get better temporarily and then come back, or if they're not responding, or you have an injury and it gets worse, whatever, then of course we want to know about that. And if things are going in the wrong direction, then of course we'll kind of change tactics.
Do you ever give patients a timeline in terms of you need to wait X amount of weeks before we make a decision for surgery? Or do you leave that open-ended?
Unfortunately, sometimes the insurance companies set that for us, where even if we want to do a surgery, they'll say, well, you haven't done 6 weeks of conservative management, so we're not even going to let you get an MRI scan. We're definitely not going to let you do a surgery. But I would say usually we can tell within about a month whether people are getting better or not. So I tell the patients, you know what, try the anti-inflammatories, try the therapy. 2, 3, 4 weeks. If you say, you know what, I'm doing everything they've told me to do and I'm not any better, then by all means come back and see me. Versus if it's gradually getting better over a slow period of time, over the course of a few weeks, really got to buy in and sell out to the non-surgical treatment and really give it a chance.
And just for the listeners here, just to make things clear, when you're doing non-operative treatment, you're not expecting these to heal, correct?
That's right. So the tear isn't going to knit itself back together and disappear. However, meniscus tears on the inside part of the knee that are degenerative in nature can often exist with no symptoms. So there's been research that shows if you get MRI scans on people above the age of 40, can't remember if it was 40 or 50 in that study, but a pretty significant percentage of people will have meniscus tears even if they're having no symptoms at all. If you just get an MRI scan on people that have no symptoms. So the fact that the tear's there doesn't mean that it has to be symptomatic. And the fact that it is symptomatic and hurting now doesn't mean it has to hurt forever. It definitely can calm down and the pain can go away, even though the meniscus tear, if you got another scan later on down the road, would still be there despite the fact they're not having symptoms.
Now let's go the other way. If it's obviously not going to get better, do you ever see these things get worse and make the surgery decision after that? Or is there ever a point where it's too far gone and you can't do anything surgically?
There's not really anything that is going to take it from something that we make it to the point where we can't fix it, I guess. That, really with degenerative tears, if they're relatively small tears or if they're larger tears, oftentimes we take out about the same amount. So if you try non-surgical management and it doesn't work and we have to go back, it's not like we've done any permanent damage to the knee. That meniscus that was torn was already torn and not doing its job properly. And it's not going to change anything in the long term if we delay treatment trying to get them better non-surgically. Of course, you have to look at the flip side also, that if you operate on every one of these you see and some people don't get better, then you wonder, should I have done this in the first place? Would they have been better if I hadn't have done surgery at all?
So now that we've talked about surgery a little bit, can we get into more of the details of that? You said go in and take out a portion of the meniscus. Can you go into more details about what the patient would expect or what you would do surgically for these patients?
Yeah, unfortunately, once the meniscus is torn and it's a degenerative tear, that means that if you looked at it under a microscope, you would find that it's not healthy meniscus. So if it is torn in a degenerative fashion, you can stitch it back together if you want, but it's very unlikely to heal. So in that case, we just take out the torn piece. We try to preserve as much of the meniscus as we can. It used to be, 30, 40 years ago, we didn't understand the vital role that the meniscus plays in protecting the cartilages on the end of the bone and preventing arthritis, distributing force throughout the knee. And if there was a tear, they would just cut out as much of the meniscus as they could because they didn't think it was necessary anyway. Over time, we figured out that the more meniscus you take out, the longer, the bigger chance you have of getting arthritis on further down the road. So we do try to take out as little meniscus as possible. However, it's usually the undersurface of the meniscus from the back attachment of the meniscus up into the middle part of the meniscus that is the bad part, and that's the stuff that has to go. I've seen a lot of patients who have come back for second opinions after they've had prior scope surgeries where they just haven't taken enough meniscus out. They've nibbled it back to a little more of a stable rim without taking all of the undersurface portion of the meniscus that's degenerative out, and unfortunately in that case patients often require a second surgery, have persistent symptoms, and have to end up going back to the operating room, which is of course what we want to avoid.
Now, when you make the decision to have surgery or for you to operate on them and you're in the operating room, is there any consistent other findings? When we look at MRI scan, and sometimes it's tough to decipher if there's any other issues going on with somebody's cartilage around the knee joint or whatever. How often are the meniscus tear surgeries that you're performing just a meniscus tear, or are there oftentimes other issues that's going on that you have to address at the time of that surgery?
And most of the time, it doesn't necessarily add another procedure, but there can be other findings inside the knee. So if the meniscus has become degenerative, sometimes the cartilage on the end of the bone, the articular cartilage, has some mild degenerative changes as well, which may or may not be as evident on an MRI scan. So it's not uncommon for us to take a meniscus tear out thinking they have no arthritis because their joint spaces are normal on regular x-rays, and then find that they have some mild degrees of arthritis in the knee. Now, that doesn't necessarily change the fact that they can still get better, but that is something we find. Every once in a while, we'll find a small tear in the meniscus on the outside part of the knee, on the lateral side of the knee. We'll clean things like that up. Sometimes we'll find some wear and tear changes underneath the kneecap. Sometimes we'll find something called a plica, which is a thickening of the inner lining tissue of the knee that also usually happens on the inside, can have some similar symptoms to meniscus tears. So usually if we'll find those, we'll take those out as well. But the extra things that we find, very rarely do they actually alter the patient's progression further on down the road, or then they usually don't alter the patient's rehabilitation.
Speaking of rehabilitation, that was my next question. So the patients have had surgery now. What does their process look like from there? Are they going home the same day? Are they staying overnight in the hospital? And then what do the next few days look like? And then rolling into postoperative rehab?
People go home, come in, have the surgery done, go home the same day. We have them kind of just take it easy for a couple of days. So if we did, I did a meniscus surgery on someone today. He went home today. He'll come back to see the therapist on Wednesday. But for the first 2 days here, he'll really just be down with the leg elevated, with a cryo cuff on, trying to give some cold and compression, and really just taking it easy, trying to keep the pain to a minimum, try to minimize the swelling, and then give them a jump start with therapy by avoiding those kind of complications. A lot of people will come to me for second opinions that have had surgery elsewhere far down the road, 6 months, a year later, who said, they told me I didn't need therapy. They told me once the meniscus was out, I would know when my knee felt better and I would get back to activities. And that can probably work for a lot of patients. But if you miss on that kind of patient, now you've gotten later on in the process and you've gotten really behind and you have to play a lot of catch up. So that's one way to go about it, is to try to minimize and not do therapy unless you start having problems and need to catch up. We look at it from another perspective as, let's avoid those complications from the beginning, do a relatively small amount of rehab visits early on, make sure the patients get off on the right foot and get back to full activities, and avoid those complications and having to play catch up down the road.
Before we get into the details of what that rehab may look like, a common question that we get when patients go into surgery is, how much time am I going to miss from work? So maybe a scenario of somebody who has a sedentary desk job like an accountant, and how much time you anticipate them to miss, and then somebody who's a very active job like a construction worker, for example, what would you anticipate them missing from a work standpoint?
For the majority of people with sit-down work, they'll miss the first couple of days while we have them down, only getting up to go to the bathroom and back. We'll usually do that over a weekend. So we'll do a Friday surgery. We'll have them spend the weekend down. We'll have them come back for a Monday therapy visit. And then if they have a sedentary job, if they work from home, if they have a short commute, if they're going to be on their butt most of the time at work anyway, then there's no reason they shouldn't be able to still go to work. So a lot of those patients we'll get back to work relatively quickly. For people who have more active jobs, so for people who, clean houses, for example, or if they are salespeople where they have to be in the car more and have to get around job sites, or if they have supervisory roles in a business or construction work, things like that, where they're going to be up on their feet a lot more, maybe we'll have them take another week off after that. But most people will get back within a week to 10 days to work. Now, if there's people, there are some situations sometimes where people say, I have a very physical job, like, I'm a lineman for the electric company, so I got to be able to climb up poles. I got to be able to, move heavy equipment. I have to be able to carry heavy things. I have to be able to do a lot of more physical labor. Those patients will sometimes be off work 2-3 weeks after surgery and take a little bit longer. So we have to have a discussion with each patient. What's your job? What are your job expectations? How flexible is your job for return to work? What kind of transition can you have back into work, and adjust accordingly? If somebody says, I have a relatively sedentary job, I have a very flexible schedule, my employer's willing to work with me and, do whatever I need to. If I need to take off unexpectedly, they're okay with it. If I work from home, I can work on the computer, whatever, then they can get back much more quickly. Versus if somebody says, I have a physical job, my job doesn't have light duty, they won't let me back on the job site until I can do everything that I need to do. That's going to obviously extend it to something like a month or 6 weeks if it's really more restrictive in that way.
Now, getting into more of the details of rehabilitation, can you go over really the stages? What are the goals you're looking for in the immediate time after surgery? What are the goals you're looking for more in the late stages of rehab? And when you typically anticipate those goals to be met and the patients to be discharged and feeling better from this tear?
At the beginning, we're just trying to keep the swelling down, get the range of motion to be good, and control pain. So for the first couple of days, we keep them down, really only getting up to go to the bathroom and back with the leg elevated, cryo cuff on, really just taking it easy. We have them take anti-inflammatory medicines and Tylenol regularly and scheduled for the first several days to try to get them a steady level of anti-inflammatory medicine in their bloodstream as well. And then once they get back up on their feet, they're doing so kind of progressively, starting to work on range of motion. At a second appointment, which usually happens about 10 to 14 days after surgery, usually by then they have their knee extension all the way back full. They have the majority of their bending back. Maybe they'll be at 115, 120 degrees of bending at the 10 to 14 day visit. And then we'll start them on some light biking, light strengthening, light exercise, things like that. By the time the month visit comes around, so 2 weeks later after that visit, usually they have all their motion back, their swelling's mostly down, their pain's pretty much gone, and now we're starting to really push the biking more and add strengthening. And around that 4-week time period, usually the first time we actually test their strength. And if their strength is back to normal, then we can, symmetric to the opposite side, then we can progress them back at whatever speed they want to back to full activity. If they're not quite there at the 4-week mark, we may do more strengthening for a couple more weeks and recheck them. I'd say the majority of patients are usually back to full activities within about 4 to 6 weeks, and that's kind of what we tell people to plan on. Of course, that's variable depending on if somebody says, I'm pretty sedentary, I just want to be able to, go to my kids' ball games, I have a sit-down job, I like to ride a bike, a couple times a week, and that's it. Then they're going to get back a lot quicker than somebody who says, I have a pretty physical job, I like to, when I get home, I like to work out, I like to play pickleball, I like to play tennis, I like to run. That's going to take a little bit longer, obviously, as well. So similar to work, we have to discuss with people, what are your ultimate goals from an activity perspective, and how does that affect how long it's going to take you to get back?
So that was a pretty good comprehensive overview of the degenerative medial meniscus tears. But at the beginning of the episode, we were talking about other types of medial meniscus tears, specifically ones that happen at the time of ACL or in acute injuries for more of the younger patient population. So quickly before we wrap up tonight, can you touch on those other types of meniscus tears?
Yeah, at the time of an ACL injury, there's also a lot of pressure that goes onto the backside of the meniscus, and it can lead to, the majority of the time, a very specific type of tear. It's a vertical tear in the back part of the meniscus. What's different about those type of tears that's normal meniscus that got subjected to an abnormal stress that it normally doesn't see when the ACL tore. So before the injury, the knee was completely normal. During the ACL tear, the knee kind of comes apart temporarily, and the meniscus is subjected to forces that it otherwise doesn't see. And because of that, it can tear acutely from a specific injury. However, if we do an ACL surgery and restore stability to the knee where it doesn't have the ability to give out like that anymore, then that tear should ultimately heal. And we have a lot of research on that. I think we've had a previous episode about that as well. We can cover it another one maybe for Patient's Place as well about meniscus tears at the time of ACL surgery, but most of the time those will heal on their own. And there's another type of tear called a posterior horn avulsion, where instead of the meniscus tearing kind of in the back of the meniscus where it gets kind of smashed between the two bones, a posterior horn avulsion refers to a type of tear that happens all the way at the back attachment of the meniscus. And usually that happens when the patient has associated low level of arthritis. So if we get that x-ray and we think maybe the patient has a meniscus tear on the inside part of the knee, but when we get the x-ray, we see some narrowing of the joint space, that a lot of times will tell us that it's not a degenerative type, it's more of a posterior horn avulsion. Posterior horn avulsions are often associated with arthritis. They happen as there starts to be wear and tear to the cartilage on the end of the bone. It increases pressure on the meniscus between the two bones, and the patient can get a more acute pop. So they'll say, I had a little pain on the inside maybe, but then I stepped down off a curb and felt a big pop on the inside in the back of my knee, and it really hurt a lot, really made me swell, as opposed to the degenerative types that we've been talking about so far that the patient says, I didn't do anything. I don't know what the heck happened. So with posterior horn avulsions, usually it'll be a more acute pop on the inside part of the knee, and when we do the x-rays, we'll often see a little bit of narrowing of the joint space. Those are treated in a totally different way that's probably beyond the scope of tonight's talk, maybe another episode of Patient's Place in the future.
Excellent. Well, I appreciate you going over that. And I do agree. I think those are some good opportunities to put those into another Patient's Place episode so patients can get some information on how to handle those injuries. But again, great information for this episode, talking about more of the degenerative type. And I think it's good information for patients to hear what options they may have. And if you're a patient out there and you've been having that nagging medial knee pain, maybe it is time to go see your healthcare provider. And if you're a patient of ours and you've been diagnosed with that, I think this gives you some good information on the options that were given at the time of diagnosis. So I appreciate you going over that. And if you want to get a hold of us, you can reach out to us on our social media pages, Twitter and Instagram at the SKC Podcast. You can reach us on our SKC Podcast YouTube or Facebook pages, or you can email us at the skcpodcast@gmail.com.
As always, our Patient's Place episodes are for educational and learning purposes only. If you have any specific questions about your care, we encourage you to reach out to your surgeon for more information.